what about future direction? I mean, clearly we discuss about preventing diabetes, but I want to spend a little bit of time going over the newer agents that are available right now for diabetes. And I will just spend some time talking about GLP-1 agonists, DPP-4 inhibitors, and the newer drug, the sodium glucose cotransporter 2 inhibitors. Now let's start with the GLP and the DPP-4, and they are all based on the concept of incretin hormones. So we now know that the GI tract responds to food by releasing a lot of different peptide hormones. The most powerful one is GLP-1. And GLP-1 has a half-life of only 2 minutes, so it cannot be given as a drug. But GLP-1 does a number of actions. It stimulates insulin secretion, decreases glucagon secretion, and of course, glucagon increases glucose levels. It delays GI motility and decreases appetite. And we know that in patients with type 2 diabetes, endogenous GLP-1 levels are decreased. But in the body, GLP-1 is degraded very rapidly by the enzyme dipeptidyl peptidase 4, DPP-4. So there are different strategies to prolong GLP-1 action. One is to give an active molecule that is a GLP-1 analog, or to block DPP-4 enzyme, so it decreases the endogenous degradation of this hormone. In the US, we have a lot of GLP-1 agonists. These are the drugs that are commercially available here, and DPP-4 inhibitors. And we use them selectively, and they have some interesting characteristics. So some studies showing you, these are patients that are optimized with a basal insulin, but their hemoglobin A1C is still elevated. So in this study, they were randomized to either take prandial insulin 3 times a day or taking an injection of a GLP-1 analog. GLP-1 analogs, they're all injectable drug, either daily, twice a day, or once a week. And as you can see, GLP-1 analogs work exactly the similar way. But what they do, they induce weight loss. So this was about 3 kilo weight loss, while prandial insulin induces about a 2 kilos weight gain. So patients lose weight instead of gaining it. There is also less glucose variability. Now that we have, as a research tool, continuous glucose monitor, in the study that was recently published, if you look at patients randomized to basal insulin plus oral agent, basal insulin plus a GLP-1 analog, twice a day premix insulin, or a basal bolus insulin regimen, the patient with a GLP-1 analog has less hypoglycemia, less hyperglycemia, and they were in better control than with the insulin level. So it seems to smooth glucose excursion during the day even more. DPP-4 inhibitors, this is a study with sitagliptin, Januvia, but basically shows similar effects. So the A1C come down significantly, about a 1% decrease. The DPP-4 inhibitors are oral agent, once a day agent that are quite effective. They do not induce weight loss, but they do not induce weight gain. And then recently I've been talking more about the SGLT2, sodium glucose cotransporter 2 inhibitors. And these drugs have been discovered because we know from normal physiology that in the kidney tubule, about 90% of glucose that is filtered is reabsorbed through the SGLT2, 10% by the SGLT1. And there are normal individuals that has a mutation in the GLT2 transporter, and these patients are the patients that have glycosuria, but they have absolutely normal renal function. They do not have diabetes. They have a perfectly normal life. And so pharmacologically, now we have drugs that block the SGLT2 transporter, and they can induce glycosuria, and by inducing glycosuria, they lower glucose levels. So this is one of the first agents, Canaglifozin. If you look at patients that are randomized to placebo or Canaglifozin or different drugs, there was a decrease in A1C about 1%. And because of the glycosuria, decreased absorption of the glucose, there was also a decrease in body weight, about 3.4 kilo for the higher dose. Now, these are interesting characteristics, not exactly dramatic reversal. What has focused the attention on these drugs was the study published 2 years ago in the New England Journal of Medicine, the EMPA-REG. And these are studies that are now mandated for all new drugs with diabetes to look at their cardiovascular safety. And what the studies have shown that patients that had type 2 diabetes, these were patient average age of 65 that had diabetes for a number of years, and they already had heart disease or they were at very high risk of heart disease. But if you look at the effect of empagliflozin in all the different parameters, there was an improvement in cardiovascular outcome. If you just look at death from cardiovascular disease, was decreased by 38%. And if you look total death, was decreased by 32%. Hospitalization for heart failure, or the primary outcome that was a composite outcome of heart attacks, heart failure, and death, was significantly reduced. So clearly there was a cardiovascular disease benefit appearance at 3 months. In this study, they really wanted to have the same hemoglobin A1C. There was a small hemoglobin A1C difference. But because of studies like this, the FDA has approved these drugs as for the treatment of cardiovascular disease in patients with diabetes. And this is just a busy slide, but it shows that there are a lot of large outcome studies that have been done since 2008, both the DPP-4 inhibitors that I showed you before, the GLP-1 receptor agonist, or the SGLT2 blocker. And as you can see, the DPP-4, they have neutral effect on cardiovascular disease, but at least 2 out of the 3 GLP-1 studies that have been published have shown a protective effect in cardiovascular disease, and 2 out of the 2 studies that have been published in SGLT2 also have a positive. These are ongoing studies that have not been published as yet. But so it is very exciting that now we have drugs that not only decrease glucose levels, but they can potentially decrease cardiovascular disease in this high-risk patient population.